Question about...
Okay, this is a question. Is there a role for somatostatin analogs in atypical carcinoid with moderate Ki67 and no metastasis? Well, I would actually say no. If there is no known disease, there is no data at all favoring the effect of somatostatin analogous adjuvant treatment in patients without metastasis. So I don't think that we have scientific evidence for this today.
Yes, maybe I could ask a question. I enjoyed both of your talks. Tell me, for the lymph node dissection, is there a size criteria, like 1 centimeter, 2 centimeters for lung carcinoids, in which you would not perform a lymph node dissection? Thank you.
Actually, I'm not aware about any size criteria in the literature. As you know, it's a rare tumor, so there's no randomized trial. There's no evidence base, so it's a judgment call. If the patient is very fit, you will try to do as much dissection as possible. But if you have metastasis in lymph node bilateral, that it's almost impossible technically to resect, then you will go for alternative therapy. But it's very rare, actually. Most of the time, you can do a resection and get all the lymph node out. You know, I have seen very rarely a patient that can be resected for the criteria of the lymph node metastasis. You know, so I saw a question actually if we can have metastasis in the lung. Actually, yes, I've seen patients with a bunch of metastasis in the lung that there's too much tumor that you can resect. And I'm not sure if they are lung metastasis or they are different multiple primary. But yes, it's possible. It's rare, but it's possible.
I completely agree. Lung metastasis, I forgot to mention that on my slide, but you're completely right there. Then there was a question to me. 5-HTP PET is already available in Sweden. Yes, it is. We can get it within a few weeks. The only problem with 5-HTP PET is that the synthesis is very complicated, which means that if you want to come for a 5-HTP PET, I strongly recommend that you have an open ticket because sometimes the synthesis fails and it may take a few days until we can have the PET, but actually we can have it. Normally we have only a few weeks waiting time.
I have a question here about the follow-up. Actually, we mentioned a long-term follow-up. I follow my patient for life, basically. You know, I just tell them when they will be 90 years old or 100 years old, they can stop coming. But because for a few reasons, first of all, you can have long-term recurrence or metastasis, and secondly, it's almost like true for all cancer. They can have a second primary. You know, if they are already at risk to have one, you know, well, they could have a second one like 2, 3, or even 10 years later. So I follow my patient for life. Obviously, not every 4 months, you know, like that's at the beginning, but later on it's every year, and sometimes we skip to every 2 years and something like this. Should we do CT scan and X-ray? This is very hard to answer this question. Again, there's no evidence-based medicine. I just do CT scan most of the time, but if I'm not sure, I will get a chest X-ray. But if I'm not sure, I will get a scan maybe once a year. But you have to remember, if you do a scan for 20 years, that's a lot of scans. So you don't want to accumulate too much radiation exposure. And Dr. Renberg, do you follow otherwise with chest X-ray, but with the other?
Well, I never do chest X-ray actually, but I do CT scans normally. In the beginning, maybe once or twice a year, and then later maybe once a year, and I do the octreoscan scan. If the initial tumor was positive, I may repeat the octreoscan scan maybe every third year or something like that. In some patients, instead of CT, I do the MRI in order to limit the radiation. But I think that you should have some kind of imaging method at least once a year. In the beginning, maybe twice a year. And that depends. In patients with atypical carcinoids, must be followed more close, as I said.
Right. It depends also if it was a very small tumor, completely resected with a low probability of recurrence, then you probably don't need CT scan. But it was a fairly big tumor, so then I will go with CT scan. I guess it's judgment call. You know, every patient are sort of different. You know, but
of course.
Yeah. Any other question?
There was a question here for the data on response to temozolomide for how long follow-up. Well, we have actually used it now for about for 4 or 5 years, and I have seen patients responding for at least 3 years. And of course, the maximum response duration it's impossible to tell you about because we haven't had it so long. But at least some years patients may respond, but exactly for how many, not possible.
One more question. What do you do, Dr. Gamber, what do you do with your patients with pulmonary disseminated neuroendocrine hyperplasia, tumorlets, or the multiple neuroendocrine tumors in the lungs?
Well, if they have multiple tumors in the lung that are impossible to resect, I must consider either chemotherapy or peptide receptor radionuclide therapy to treat them. And it's whether, I must also say that whether chemotherapy or peptide receptor radionuclide therapy with lutetium should be the first-line treatment in patients with lung carcinoids, this is controversial. We don't know that.
I have a couple of them, and they remain stable for years and years. They have rather benign.
If they have, not if they have hyperplasia, but if they have metastasis, I treat them. But hyperplasia.
Hyperplasia, so in the original biopsy there were already multiple foci.
If there are no remaining tumors, I don't do anything.
Patient that I biopsy, there was a lot of little tumorlet.
Well, if they have tumors, as I said, if they have obvious tumors, I give them treatment. Yes.
Any other question? Just a little comment. I had a video of a surgery I did, and I was not sure if I will show it during the presentation because there was a bit of blood, not too much, but still. But we can maybe show the video during coffee break if you want, and some people who want to watch it, you're welcome to ask me a question. That's maybe an option. So, and if you don't like blood, then you can go to have a coffee. Thank you very much. Any other question? No? Okay.
Thank you very much.
Thank you.
All of you for listening and for inviting me.